There we go. Okay, so I'm going to go through a little bit of history and logistics. Dave's going to give you a literature review, best evidence, and Adam's going to give you some of our experience in our first activation. So away we go. So we've had access through the Vancouver General Transfusion Services to blood since 2013, but we had to go there to pick it up. So this really made it very difficult and frequently used, added time, and quite often we just didn't have that time. So we'd use it maybe once or twice a year to do that. So, but in February of this year, we started stocking 4 units of bone eggs out at Station 280 at the Helijet hangar there. And we've done this with a lot of work, working with Vancouver Coastal Transfusion Services, and it's been a long time coming, and really things that changed were several things. Some is technology, but also a change in sort of evolution and attitudes of the use of blood. It's created a whole bunch of things that we had to get, stumbling blocks we had to get over, including a lot of training and competency. The paramedics have to go through the same transfusion training that registered nurses do that give blood. We had to look at how we would store the blood, our human resources of how Vancouver Transfusion Services have to put in about 4 hours a week to this, and there just weren't any transfusion technologists to be able to do that for a period of time. So that was a stumbling block. The logistics of getting the blood from Vancouver General down to the airport and back again, the costs, the liability, the quality and control of all this. And also we have to return every bag back to Vancouver General Transfusion Services. So a lot of different logistics that we had to get over. Storage, just get a fridge. You can't just get a fridge, and you can maybe, if you have any other questions about that, talk to Russ McDonald from Ontario with that. It has to be a special fridge, a whole bunch of things. It has to be monitored. It has to, you have to know when it's not working because of the potential of contamination to the blood. And it has to be somebody, there's a FTE portion involved in that. It's not just get a fridge, right? But we learned from Manitoba Stars a few years ago about these new coolers. There's sort of new technology with them, 96 hours of ability to store the blood if they're unopened. So, like I said, not enough text, take some time. We have to make sure they're packed and sealed, documents checked, return blood if they're not used, they have to go back, and then it gets put into the immediate use in the hospital. So we had to sort of set all that up. It costs about $10,000 a year for the tech, which we pay for, BCTHS pays for, and then it costs about another $10,000 just for the logistics of moving the blood back and forth to the airport. And we lock it up in the same room as night vision goggles, so it's very, very valuable. We've worked through the whole patient consent. The EPOS physicians are a big part of that. We've talked about that on our telephone calls, but a big part of it is that somebody else other than a VGH or coastal physician is now allowed to authorize the use of the blood. And that was another big legal stumbling block that we worked through and had to get over. So there's all these different things that pile up to prevent use of the blood. Really want to thank Stars Manitoba. We looked at their program in quite a lot of detail and copied it shamelessly. And hopefully this summer we can start the process for blood up in Kamloops, so that's coming down the pipe.
Perfect.
Okay, Dave, whistle through it.
All right, great. So my part of the presentation is going to be giving sort of a whirlwind overview of some of the evidence behind pre-hospital blood products, and kind of get an idea. You've heard joked this conference about being on the cutting edge. Some of the things that are possibly coming down the pipeline is what we'll talk about in this presentation. So things that you may have heard about are low titer whole blood, freeze-dried plasma, fibrinogen concentrate in the pre-hospital setting. So we'll talk about all that stuff. So before we go into it, just to set the background, I think it's important to give kind of a bittersweet credit to the military, where a lot of this, our understanding that we use in the pre-hospital world today, vis-a-vis trauma resuscitation, has come from. So that's been codified into sort of the damage control resuscitation doctrine, and this was kind of put into a formal doctrine in 2004 by the U.S. and the Department of Defense. And this is kind of a slide showing 9 basic principles for damage control resuscitation, but I'll draw your attention to 2 of them that are relevant to what we're talking about today, including using sort of massive transfusion in a pre-specified ratio, and then using blood products that optimize hemostasis. So when we talk about this pre-specified ratio, all of you I'm sure are familiar with it. It's what we use in our trauma bay. It's the 1-to-1-to-1 ratio. So where did that actually come from? So main basis for it were 2 studies. The PROMPT study from 2013 essentially gave us the indication that balance was associated with decreased 6-hour mortality. And then that was followed up by the PROPER study in 2015 that sort of cemented the 1-to-1-to-1 ratio that we now use today. So what about optimizing hemostasis? So obviously transfusing products in a balance ratio is one way to sort of set yourself up for success in terms of optimizing hemostasis. But in the pre-hospital setting, what about individual components that we might use on a helicopter, and how does that work towards getting good hemostatic control from a blood products resuscitation standpoint? So in terms of packed red blood cells, we're going to talk about, obviously you're hearing about our experience with BCEHS and Alberta as well. The evidence base for that really comes from 3 main studies, one out of the military from the UK's Obert team, and 2 in the civilian setting, one being pre-hospital packed cell use, and then the second being pre-trauma center packed cell use. As was mentioned in a previous presentation, the evidence base and quality of literature for packed red blood cells may, in fact, in terms of study design, be a little bit inferior to what has, and obviously we'll talk about PAMPER and Combat and the problems with those trials, but those were big randomized control trials, so that is something to keep in mind. So you'll hear about our experience. Obviously our colleagues in Alberta, STARS published in CGEM in 2018, literature about their experiences in rolling out a pre-hospital packed red blood cell program. So state of plasma, obviously this was the big ticket item this past summer. There were 2 big studies, PAMPER and Combat trial, both of which were funded by the US Department of Defense. And interestingly, they reached opposite conclusions, and that formed the subject of our debate yesterday. So the PAMPER trial was published by Sperry in the New England Journal of Medicine, came out in July, was, as you know, a pragmatic, multi-center, randomized control trial, looking at a primary outcome of mortality at 30 days, and compared thawed plasma with standard care resuscitation during air medical transport. So main point with PAMPER was this almost 10% difference in the primary outcome of mortality at 30 days. And obviously the Kaplan-Meier curve kind of speaks for itself. Pretty early separation between the 2 groups after about 3 hours after randomization, and persisting all the way through to 30 days after randomization. However, as is usually the case with studies, there are issues. Some of them have been talked about, but ones that I wanted to draw your attention to. If you look at their in the paper about the differences between the treatment arm and the control arm, they actually had a statistically significant difference in the volume of pre-hospital crystalloid solution between those 2 groups, and as we know, that's bad news when it comes to quality trauma care. So that certainly could have played a role. Secondly, TXA is something that we're all familiar with and has certainly a role in pre-hospital trauma care. Wasn't really mentioned in the study in terms of how it played out between the 2 groups, and wasn't really talked about at all. So the Combat trial reached the opposite conclusion. That was from the Lancet. It was a RCT, but this time a major metro urban trauma center, looking at a similar primary outcome of 28-day mortality after injury. And as you'll see, the results were a big pile of negative results, essentially. There was no positive finding found. And some of the reasons for this, in terms of the study design, if you were in the control arm, you would open up your allocated box and you'd get a bag of frozen water. And once you got that, you would say, okay, this is it. I'm going to chuck that, and I'm going to go straight into my usual trauma care. If you were in the treatment arm, you would get your frozen plasma, and on board the ambulance you had this device called the plasma therm, which was sitting there, and you would have to, the one attendant in the back would have to go through the process of thawing this plasma, which on an already short transport time is certainly going to tie up your ability to care for the patient in all of the other ways that we know are important for good trauma care. So I think this was a big flaw in the combat trial and probably explain some of the results. Secondly, the study was also statistically underpowered for what they were looking for. But in terms of differences between the two, one of the big differences was in transport time. So combat was 19 minutes, PAMPER was 42 minutes. And so I looked into our average. I couldn't get an exact number for our regular transport time, but I did find from 2012 and 13, our auto launch time from call to ED was 2 hours, 2 minutes, and 28 seconds. So I'm inferring that probably our BCHS context is closer to the PAMPER context than it is to the sort of Denver major urban center scoop and run context. So another thing, so obviously plasma, there are practical and logistical considerations to it. It's a frozen product. Once you unthaw it, it's good for 5 days. The unthawing procedure takes time. Freeze-dried plasma is a potential answer to these problems. It is coming down the pipeline in the US. There's a company called Teleflex that has a product called Replace that is currently undergoing FDA approval. It's expected, from what I've read, to be coming in about 2020. And I'm not sure the status in Canada after that, but certainly it is making progress in the US. So what about fibrinogen concentrate? This is something that some of the VGH trauma surgeons are interested in and are believers in. Not to bore you with the coagulation cascade, but I'll emphasize that at the very bottom of the cascade, fibrinogen, one of the building blocks of forming a good stable clot. So obviously if you want to have good hemostasis, you're going to want to have the appropriate building blocks to get there. And that's the reason why at VGH, when we run a ROTEM sample on a major trauma patient, we look for what are their fibrinogen levels, we look at that alpha angle, and we make sure that we top up those building blocks. So what's the evidence for fibrinogen? So in 2016, there was a big meta-analysis that looked at 14 randomized control trials, about 1,000 patients, and found a big effect in terms of all-cause mortality, as well as some associated benefits in terms of reduced bleeding and lower number of units transfused, without any notable sort of adverse events like thrombotic events or MI. Notably, cardiac surgery, as you saw up there, one of the problems was the patients that made up these studies that went into meta-analysis were primarily cardiac surgery patients, so how applicable is that to our setting? And secondly, many of the studies were considered to have high or moderate risk of bias, and it wasn't adequately powered in terms of the studies that made up this meta-analysis. Another one that's more recent is a single-center RCT that was actually from Innsbruck, Austria in 2017 called the RETIC trial. And it was looking at comparing fresh frozen plasma to coagulation factor concentrates, of which the majority of the CFCs that were given were fibrinogen, but also included PCC or factor VIII concentrate. The study was very complicated, but my main takeaways were that it was obviously terminated early because they found a worse outcome in the fresh frozen plasma group. And secondly, the CFC group required less rescue, which in this study was additional doses of CFC itself, and then there was less massive transfusion associated with that. So I think that's pointing us in a direction, and certainly there's a theoretical underpinning why fibrinogen might be something to look at. And I think we should note that our European friends have already included fibrinogen in their 2016 guidelines for the initial management of patients who are expected to have massive hemorrhage. So it's on par with plasma. In Canada, this is something that's already here. It's not like freeze-dried plasma where we have to wait for what's going on in the States and approve it here. Product fibrinogen concentrate called Resuscitate, already approved here, has a shelf life of 5 years, can be stored at room temperature, easy to reconstitute. So it's certainly, from a practical perspective, something that may be very useful for our constraints in our setting. So you've heard from Dr. Christian that there was mentioned about whole blood that they're using in London and other places. It's also being used in the US as well. So I just wanted to talk about it because I think this is something that is on the radar for the future in Canada, and there's a lot of arguments for it. It was kind of rediscovered, whole blood had been used way in the past, but rediscovered with sort of walking blood bank transfusions on the battlefield in Iraq and Afghanistan, including by the Canadian forces. We're using fresh whole blood. There are 2 big studies two studies that came out of it, out of the wartime experience that showed benefit with whole blood. But I think it's important to note that their studies were looking at fresh whole blood, which is literally put an IV in one guy and it's into the next guy. And so from a civilian setting here, from an infectious disease standpoint, that's something that's probably not as feasible. And so what we would be looking at in the Canadian context would be what's called cold whole blood, which is a whole blood donation that's not separated into components and then stored by refrigeration. So the rationale, obviously it makes sense. It's replacing exactly what's coming out with the same thing going back in. I think also from a paramedicine perspective, it reduces cognitive burden in an otherwise sick and unstable patient. You're not worried about hitting those ratios. You've got your whole blood, it's got everything you need, you set it and go. It also minimizes crystalloids. So if you consider that each component that gets separated out of whole blood needs to have a certain amount of preservative and diluent there. If you are putting together what is essentially whole blood at the end of the line by adding the components together, you're actually, that amount of diluent is adding up. And as we know, that functions like a crystalloid, it's not good. So whole blood is something that would minimize that. Another thing to point out is that some in vitro data, and this is early and I just got some mention of this in the literature, depending on how the whole blood is processed, and I'm not a hematologist, but I think Dr. Christian had mentioned the constraints in the UK vis-a-vis mad cow disease in terms of whether they would have to, how they would filter out and take out platelets in whole blood. But depending on how you do it, if you were to leave the platelets in, there's some evidence that's starting to come out that maybe those platelets would be beneficial from a hemostatic perspective to have them remain in the cold whole blood product. So what are the practical considerations? So you hear this low titer. Obviously type O blood is the universal red blood cell donor, but that type O patient may have antibodies against other ABO blood groups, so anti-A, anti-B. What you wouldn't want is enough antibodies to be there to have a transfusion reaction. So different definitions of what constitutes low titer, but it can go from anywhere from 1 in 256 to 1 in 50. The US military is using that higher cutoff. Pittsburgh, which is one of the sites in the US that is using whole blood, has picked the lower cutoff. As well, in terms of more practical considerations, the shelf life of whole blood, 21 days. What I've seen, most places are using about 14 days as the time that they can utilize the product. And the literature thus far is early. There are a number of studies ongoing. There's some in silico modeling, which shows a benefit of whole blood versus component therapy. There is a study showing that it is safe to use in male trauma patients, which sort of paved the way towards getting approval to trial this in the US. And then there was the Cotton study, which was a small RCT that when you look at secondary sensitivity analysis, excluding TBI patients, there was reduced transfusion times with whole blood. So this is not relevant to us in Canada, but I think it's important to note just to see the direction things are going. In terms of blood transfusion in the States, it's regulated by the American Association of Blood Banks, and they have this transfusion standards manual that all hospitals are expected to abide by. And prior to very recently, using uncross-matched whole blood in the field with a patient that you didn't know the ABO blood group was not allowed. And so 217 experts in trauma care, and I'll go back a slide just to show you this trauma hemostasis oxygenation research consortium, actually got together and sent a letter to the AABB asking for a change in that policy, because they truly believed that whole blood had a lot of potential and that it was safe and worth using. So that policy did change. And now in Mayo Clinic, San Antonio, in Pittsburgh, they're using whole blood. And here, reading some blog posts, it sounds like the data is encouraging out of Pittsburgh. Obviously, the formal literature is forthcoming. And another slide that I found interesting is this is what's going on around the world. So you can look and see who's doing what and where. And you see the Israelis seem to be ahead of the curve. They're using everything. And whole blood in New Zealand is also being used. And I actually ran into someone from Colombian who had done a rotation during his residency with Auckland Hems. And he was saying that what they did to minimize the sort of resource drain of having specific whole blood donations pulled out of the general donor pool was they would rotate the whole blood units in coolers for the Auckland Hems service, and anything that would go unused would then go back into the regular donor pool, would get split into components, and as though it had never been taken from the system. So that is what's going on, and we'll leave it to Adam to tell us about our PRBC experience.
Perfect. Brilliant. All right. So thank you very much. I guess what I wanted to highlight was just some of our actual experience here in British Columbia using blood products. So as Dr. Wheeler described, in 2011, we started the conversation with a variety of stakeholders about the idea of having this project. So what it led to was this inter-facility program where we could request product in an ad hoc basis through Vancouver General, which was essentially when we get a call. They were typically all inter-facility calls because timelines didn't work for our major trauma or auto launch program. So we would get that call, we would assess the patient by calling the sending facility. We would determine, wow, okay, you either don't have enough product or somebody's in a current state that suggested that they're going to need significant product to transfer. So we would then contact VGH and we would request units. Well, that created some significant headaches for TMS. One, which was we literally pushed the panic button there and all operations stopped there while they packaged our product. All right, well, that became incredibly disruptive for TMS as well. So what we looked at here, but it was the system we had at the time, okay? So what I thought I'd look at is we actually had a rather low yield. We ended up in 4 years only activating this program 9 times. So there were 9 patients that were transfused. There were a lot of reasons as to why this happened. That came from just providers being unfamiliar with the program. We started having a greater turnover in our critical care paramedics, and it was de-emphasized within the group. 2, just as a result of the interfacility transport, the mean time to getting product, it added almost an hour before we could even be wheels up. So there was some significant detriment there. And then lastly, we started seeing TMS here in Vancouver starting to resupply or decrease the supply to a lot of these smaller sites that typically only had 2 to 4 units at a time. Now they've got 6 or 8. So, but you can see here, just an idea. We're seeing an interesting cohort. So from there, some pre-transfusion physiology suggestive of what we were looking at. We were trying to use some of this data when we were designing what would our clinical practice guideline look like for transfusing people in the pre-hospital setting. I think the most important part of this slide is the fact that we had 100% traceability. And really, that's what we're going for right now, is to not try and waste this incredibly valuable donation of human tissue. So, phase 2. We've exited phase 2. We're now into, exited phase 1. We're now into phase 2, which is this idea of actually having blood at the station. So instead of making that phone call, we would actually have packed products in these CryoCube coolers at our station that we can deploy at any time. So immediately right there, now that opens up the possibility for transfusing trauma patients in the field. It decreased the time that we would get off the ground for facility transfers and such. So these cubes here, Credo was purchased by Pelican several years ago, and these are Generation 4 phase change material coolers that were tested in Afghanistan to an exterior temperature of 40 degrees and held the interior temperature of between 1 to 6 degrees for 96 hours. So they were ideal for this setting. We can expose them to the elements and the product would stay intact. What we've now subsequently done is set up a courier system so that these are rotated out every 72 hours to ensure we minimize wastage. All right, inside 2 units of ONEG. So here is our clinical practice guideline that we've developed. So it's been developed with clinical medical programs, VGH Trauma Services, as well as VGH Transfusion Medicine Services. We have ongoing consultation with BC Children's with regards to its inclusion within the pediatric population. As we learned yesterday from Dr. Mackler, we're transitioning. So right now, as you can see here, what we've opted for is trauma plus an early blood transfusion needs score. show you the scoring system on the back. So it is a validated scoring system. It's purely physiologic. It does take into account things like age and type of trauma, but doesn't require any laboratory values or other diagnostics. The gold standard right now would be the ABC score, but it's predicated on people performing an EFAST. Right now, about 50% of our paramedics are trained to use ultrasound, so it didn't make sense to roll out a score that required them to use a tool that only 50% can use. The good news is that we are, as a part of our continuing medical education, retraining everybody and refamiliarizing people with ultrasound so that we can transition to the sort of gold standard scoring system as we move. So from there, we also didn't want to just isolate this to trauma. So as you can see, our second inclusion criteria was simply active hemorrhage with a hemoglobin of less than 70. There are little footnotes there that allow us to increase in the setting of acute coronary syndrome and such. Otherwise there you can see your exclusion criteria is really just refusal of blood product administration. That's still Jehovah's Witness criteria. The TMS community has removed the religious connotation associated with people who refuse blood products, and now it's just that group. Isolated penetrating heads. We use this because that was a common theme that we started seeing through other research, so it allowed us a better ability to compare our patient populations. So from there, just so an idea, pre-transfusion blood work. So we would like people to draw pre-transfusion blood work. Of course, it needs to be clinically, you need to have clinical time. So if somebody is examining in front of you, all right, transfuse them, we'll deal with this after. From there, we're just reminding people, consider things that also stop hemorrhage as well, and correct and mitigate sort of ongoing hypothermia. The bit down there with regards to EPOS. So right now in our program, we are not transfusing without talking to a physician first. That is mandated. Under no uncertain terms, we transfusing people without talking to somebody. But as I've already activated this program twice, that phone call can be very brief and very quick. This is the situation I'm at. This is what I need to do. I'll follow up later with what's actually transpired. Okay. From there, we're just making it nice and loose, 1 to 4 units to clinical response, and then to ensure that receiving facilities are aware of what's going on, so that it allows them to prepare from a lab perspective the need for potential increased product. Okay. So to give you an idea of what early blood transfusion need score looks like, it's a scoring system right now. We need to have a score greater than 5 in order to qualify based on there. So very simple, very physiologic based. It's in the app. We have hand cards. So yeah, this is what we're using right now. You can see the footnotes on the bottom there. Okay. So the exciting part of this, our inaugural activation. We literally put this out of the airport on February 10th, and by February 11th, we got our first activation. So this is actually a picture of the text messages that comes through on our cell phones as whenever we get an auto launch. Okay. So as you can see here, 2:31 in the morning, we get an NPDS code 27 Delta. It's a stabbing of multiple patients. It's up in Whistler. Okay, it's in front of one of the pubs there. So all we know is there's multiple people stabbed. So we were paged at, as you see, 2:31. By the time we got to Helijet, about 3-4 minutes later, we determined we couldn't fly. Weather. It's February, it's snowing, it's an absolute miserable night, so there's no way we're flying. All right, I guess we're driving. So we ended up driving to Whistler. Took us about 2.5 hours. This is actually a picture of the road, so thankfully we had a transport truck in front of us we could see. We arrived in Whistler by about 4:30. So it took us a little while to get there, but we made it. That's what we walked into. So inside the Whistler Health Clinic, we find a 30-year-old Australian tourist. So it sounds like he was trying to be a hero and break up a fight in front of one of the pubs in Whistler when 2 of the assailant buddies, he was trying to break up a fight when one of his buddies stabbed him twice in the back. So he took one on each flank. He'd initially resisted EHS care when they first arrived there, and they eventually agreed to walk to the ambulance. So, but this is the 2 hours post, this is what we walked into. This was a guy, if anybody's familiar with the Whistler Health Clinic, it's their resuscitation room is about the size of a washroom. So you go in there and it's incredibly tight. You have this combative patient there. You have the physicians at the head that just administered a little bit of ketamine. They're in the process of intubating him, and sort of all hell's proverbially breaking loose. So we knew quite quickly that we would need to transfuse based on Whistler's supply. So a phone call was immediately made. It lasted about 40 seconds, and yeah, there we went. So at that point, as we talked about, he'd been stabbed twice in the back, right and left flank, and he'd already had 2 chest tubes in situ with Pleurovax, and then they'd also added an autotransfuser, which will actually come in handy later. So some initial vital signs we saw. As I said, his GCS was more associated to his ketamine as well, but yeah, he was having a rough go. And that's SATs and respiratory were despite his 2 chest tubes that were in situ. So we immediately worked with the staff in Whistler Health to employ certain damage control resuscitation. So some things we worked on here. Immediately it was trying to differentiate, well, why is he still in shock right now? Is this truly hemorrhage or something else going on? So needle thoracentesis and a 3rd chest tube was placed with an immediate result. An immediate gush of blood and restitution of SATs. So we employed at that point just minimize minimal crystalloid use. We transitioned whatever normal saline he had into plasma light, and we started transfusing at that point. Okay, so he had received initially 2 units of PRVCs from the Whistler Health Clinic. Then at that point, we added 4 more from our stock. He'd filled almost in 2 chest tubes full. So he'd lost almost about 3,500 mLs, and he had another 1,400 within his autotransfuser. So we started replacing with his what we could from the autotransfuser. We were there for, unfortunately, too long, but it was a case where now we need to finally start getting on the road. It's almost 6 o'clock by the time we leave Whistler Health Clinic, because he's now stabilized to the point where we can actually take him on a 2.5-hour journey down the road in the blizzard back to VGH. He required a significant ongoing resuscitation in the back of that ambulance, and it was a challenging trip to the point where we ended up having to detour to Squamish. So probably about 15 minutes outside of Squamish, we knew that we were running out of product. He's sanguinating in front of us. We can't control him. So the decision's made. Let's call Squamish. Had a brief conversation with the physician at Squamish. This is where we're at. Can you please pack up as much blood products that you can spare? We'll be there in about 15 minutes. I'm going to come in, pick him up, and I'm going to carry on down to Vancouver General and just try and limp this guy along. So they were incredible. They called in a lab tech from home, and I was in that hospital for about 3 minutes. Gave them a PHN, managed to take my product with me, and I was out the door. It couldn't have worked any more seamlessly. So by about 8 o'clock in the morning, we arrived here at Vancouver General. It's almost 6 hours post-injury, but based on the drive times, the best we could accomplish at that time. And what a relief. So an actual photo from us arriving. So we arrived to the welcoming arms of Dr. Harvey Haas from the trauma surgeon and his team. So this is our group, and the team was well prepared. And as you can see, the benefits of letting them know that we were already transfusing is they already had product ready to go. They already had they'd already thawed some FFP, they had platelets ready to go, so we were able to try and optimize the bowels resuscitation. This is what we managed to bring them. So not ideal, but he's slightly better off than when we first found him. Just some pictures of what, so he'd ended up with, he'd had 3 chest tubes placed, and then he'd had the autotransfuser there, of which we've already dumped once back into him. So in total, once we arrived, he received an aggressive resuscitation in the ED before going to CT to try and figure out what he actually had. So they immediately gave him 4 units of FFP, some platelets, and as you can see, really they thought he was back on safe ground. Okay, good. And then we took him to the tunnel of truth, and we all know what happens when we go to the tunnel of truth. So he definitely has the positive arrow sign here, so we can see a possible right colon injury plus an arterial brush from a left intercostal artery. When we said he was on safe ground, well, he immediately decompensates when he's in CT and he's taken directly to the OR, where he then has, and this is actually him, his posterior lateral thoracotomy to repair his proximal intercostal artery. It's 2 centimeters from his aorta. So all in total, in 24 hours, this is what he managed to receive. So it's a gentleman who's certainly received a lot of product there, almost 14 units, plus almost 2,400 mils of auto-transfused blood, plus another 1,000 from the Cell Saver, and almost 18 grams of Fibrinogen. Okay. I posed this slide only because it's interesting. As the more units we transfuse, the greater the risk of complications. But then there's also the concurrent earlier blood product administration leads to typically less products transfused. So once again, in support of the idea of hospital blood, if we can achieve hemostasis earlier, we potentially decrease some of the downstream complications. I thought I'd just chat now about some of the ongoing research right now. So this is a project that I'm doing right now. We're doing a needs assessment. So we're doing a 5-year retrospective review of every auto launch that we've done in British Columbia and flown these patients to either Vancouver General or the Royal Columbia to get an idea of how many patients are out there that would actually warrant this. It sounds a little counterintuitive that we're doing this after the fact. We had the program, but the program, it got momentum, so we just kind of rolled it out, and then now I'm providing the evidence that will hopefully ensure its long-term stability. So what we're looking at right now is almost a 1,300 chart review right now, which let me tell you is exhausting. I've lost most of my medical student help right now, so we're working through it. So just to give you some rough data, what we're looking at right now. So this is a snapshot of 2012. I was able to analyze this. It looks like we have almost 150 patients that we've flown to one of our 2 level 1 trauma centers right now. And we're looking at somewhere between 13 and 15% will receive received blood at that time, with a mean unit of 5 units. So this is not something that we're simply giving 1 unit for just because. Okay? So what we wanted to look at here was where are we at here? So going back to, yes, one of the bits we're also trying to establish is we're also trying to look at all of these patients' pre-arrival physiology and applying some of the variety of the scoring systems that we're using, for example, the ETN, the shock index, modified shock index, or ABC, to see how many of those patients would actually qualify based on our current program right now. So that's still being determined right now, but it's some of the research that we're doing. So, thank you very much.